Good afternoon. This is Dong Che from Severance Hospital, Yonsei University. I'd like to open the interview session with Greg Stone from the United States. He is very well-known interventional cardiologist, and also we have Myung-gi Hong from the Severance Hospital. So please, Myung-gi Hong, start the interview with Dr. Greg Stone.
Okay, actually, this is a very good chance to us because your comment, opinion is make some new direction to us, or is something new. And also, I would like the address of some clinical aspect of in the near field. First of all, for the clinician, what do you think about currently? What is the best DS? There is a lot of the excellent stand. For example, Oshilo and Synergy and Onyx and Ultimaster. So, anyhow, what is your recommendation for the clinician who working in the field?
Well, we are a very fortunate time right now because, as you mentioned, we have many good contemporary drug-eluting stents. When you look at how it's evolved, when initially all we had was Cypher and Taxus, and they were very effective, but they had safety concerns. Mm-hmm. The polymers were inflammatory, the drugs, in the case of paclitaxel, were occasionally toxic, the devices were thick strut stents that were difficult to deliver, and we've now emerged and evolved where we have very thin strut, very deliverable stents with whether the polymers are durable or bioabsorbable. They're very biocompatible, so they have very low rates of inflammation similar to background. And the drugs have almost all now unified to be Limus analog drugs, which have a very wide toxic therapeutic ratio. And so when you look at this, overall, we have very high delivery success rates with low rates of stent thrombosis and low restenosis rates. Now, to pick one best stent is very difficult. I think when you look at many large head-to-head trials, and there have been hundreds of them now, I think that we can say that we have probably maybe 6 or 7 or 8 stents that have a very high level of evidence to suggest they are very safe and very effective.
Right.
I think to try to tell if there were any small differences between the two of them would probably require 10 or 20,000 patient randomized trials.
Right.
You know, does one have a stent thrombosis rate of 0.5% where another's 0.7%?
Right.
I mean, that's how small differences we're talking. So I think that for a workhorse device, the physician has good choices between Xience, between Promus Element, between Synergy, between Resolute Integrity or Resolute Onyx, or Cyro, Ultimaster, and there are others. These are very, very good choices. There may be specific situations where one may be a little more deliverable than another, or because of more of an open cell design, it may be easier to access a side branch, and so you have to decide those on one-by-one situation. A particular interesting issue is that of the high bleeding risk patient, in which people would like to use 1 month of dual antiplatelet therapy, sometimes 3 months, sometimes less than 1 month. And there we need more evidence. Right now, the best evidence, the best data that we have is for the polymer-free drug-coated stent BioFreedom. And as you know, that's a relatively thick stainless steel device. It's about 120 microns, but it has no polymer. It has a micro-etched surface that holds a very lipophilic sirolimus analog called BioLimus A9. And it's been tested first in the randomized Leaders Free trial, and now most recently in the Leaders Free 2 trial, which was just presented at TCT a couple weeks ago. And it was shown compared to bare metal stents to be very effective and as safer with only 1 month of dual antiplatelet therapy in high bleeding risk patients. Now, it may not be the most effective device out there, as there are some other studies that suggest that contemporary DS may have a slightly lower restenosis rate, but it is very safe. And when you're talking about discontinuing dual antiplatelet therapy at 1 month, safety is the #1 concern.
Okay.
But we also know that it is effective. It's much more effective than a bare metal stent. It reduces restenosis by about 50%. So right now, in that one particular situation, I think the evidence is favoring use of BioFreedom. but there are going to be many studies in the next couple of years, either head-to-head trials against biofreedom or other very large registries with only 1 month of dual antiplatelet therapy with, for example, Science or Resolute, et cetera, or Synergy, that might suggest that those are equally as safe and perhaps even more effective. So today I would stick with biofreedom for the 1 month DAPT situation, but I'm hopeful that we're going to have a lot more evidence in the next few years.
Is there any possibility or the probability of the developing a more advanced drug-eluting stent beyond the current the stent? Because the so excellent stent,
Yeah, they're really good.
Right.
the prevention of some ischemic event is so excellent. So we are happy about this current clinical outcome. But in the most of the study was done in the when we look at the study population, patient age is middle 60. Nowadays, middle 60 is
Right.
young.
Right.
But
I hope so.
yes, right, of course. And then, you know that the longevity is almost the patient is nowadays 90 or some 100.
Yeah.
It means that the huge number of patients need some PCI procedure, maybe
Right.
mid 70, maybe 80.
Right.
So we have to need some specific drug stent for elderly patients.
Yeah, yeah.
What is
Well, when you think about the elderly patient, what issues do they have? First of all, they tend to develop more coronary calcification. So it's very important that we develop the appropriate debulking tools to be able to prepare the vessels, whether that be rotational or orbital atherectomy, or now there's a new device, Shockwave, coming out, which we're very excited about, cutting balloons, scoring balloons,
Right.
etc. So calcium is a big problem in the elderly patients. And comorbidities, of course, is also a big problem. Not only do they have often diffuse disease, diffuse atherosclerosis, and extensive disease in the coronaries, but they've often got peripheral vascular disease, cerebrovascular disease, chronic kidney disease. Of course, they are more prone to bleeding complications.
Right.
And so, especially when you start getting to the ultra elderly, let's say the nonagenarian, 90 years and above, then we may like shorter dual antiplatelet therapy, because age in particular has emerged as a risk for bleeding more than ischemic complications.
right?
So that's why developing this evidence base so we can shorten dual antiplatelet therapy in the very elderly patients is very important.
Yeah.
And we also, of course, need very
yeah.
deliverable devices because in the elderly patients.
Yeah, Dr. mentioned a very important point for old age PTCA. So I'd like the question, very simple question. For selection of stent in the current era, which one is most important, safety or efficacy?
Safety or efficacy? It's I think it's hard to generalize for any one class of patients. What I've really learned from looking at all the studies, particularly the studies about the optimal duration of dual antiplatelet therapy, is, and this applies to elderly patients, young patients, acute coronary syndrome, stable disease, renal failure, no renal failure, is you have to weigh the risks of ischemic complications versus bleeding.
Yeah.
And we know that advanced age, for example, is one of the real risk factors for bleeding.
Right.
Okay, so on one hand, we might have an elderly patient, let's say a 90-year-old patient, with a single focal lesion. And that kind of patient I would like to treat with a good stent, and there are many good stents now. I don't think that one is necessarily better than the other, and maybe consider 1 month of dual antiplatelet therapy. So again, right now for that, biofreedom is a very good choice. There may be others in the near future. But then there may be elderly patients who too elderly and frail for surgery, but who may have left main disease and complex multivessel disease with bifurcation lesions and chronic total occlusions, where we may have to put in 4 or 6 or 8 stents and very complicated procedures, in which case we would never think of 1 month of dual antiplatelet therapy.
Right.
So in that case, the emphasis is going to be on the most deliverable stents, okay, and the ones that will have the highest rate of being free from stent thrombosis and restenosis. And I really do believe that it's very difficult to say one stent is absolutely more deliverable than the other. Or it's hard to say that one of the current devices of the 6 or 7 or 8 that I mentioned absolutely has a lower restenosis rate or a lower stent thrombosis rate than the other. They've all got good data now. So I think it's important for the interventionalist to get comfortable with one or a few stents, find out which one works for him or her, and then use those frequently, especially in the higher risk patient, like the elderly patient.
In the aspect of your study, Excel study, personally, I like it. And based on the Excel study, I think that the guideline should be changed.
I agree with you.
Yes. The low risk of the left main, it can be fixed with because particularly in some elderly patient, so the patient usually does not have only coronary and heart disease. They usually have some other, they need a surgery. And in the low risk of the left main, why not? We can fix it with a simple. So personally, that is, I think, is a very important study based on the Excel. That is the practical point of view, the practice, our practice. Okay, patient need, you have a left main, you need the heart team discussion with the surgeon, delayed some procedure, and then the surgeons say that based on the anyhow, still cavity bypass surgery is maybe better. You need the surgery.
Yeah. Well, there's a long history of left main PCI versus CABG. And of course, bypass surgery does very well for patients with left main disease, but it's major surgery. It's a big operation, and most patients don't want to undergo a big operation if there's a less invasive way to treat them. So in the early days of angioplasty, Andreas Grunsig felt that balloon angioplasty would be wonderful for the left main. It's a short focal lesion. It's very easy to reach with a balloon. And in fact, the third patient he ever treated was a patient with a high-grade left main lesion. The problem is that when the left main would either close acutely or cause restenosis, which was very hard to predict with balloon angioplasty, there was so much myocardium at risk that the patients would often present with sudden death. And balloon angioplasty couldn't fix that, and bare metal stents couldn't fix that. It really took first-generation drug-eluting stents, as shown in the Syntax trial, to have pretty good results in left main. And of course, the left main is a large vessel, usually. It's usually 4 millimeters or larger, and it's relatively short lesions. And even the bifurcation of the left main is not so complicated to treat because even the circumflex is a large vessel side lesion. So an experienced interventionalist, even in Syntax, was able to get good results in the left main. And now we showed in Excel that the results are very acceptable. And in fact, it was a safer procedure, So the main result of Excel was that within 30 days, there were fewer large myocardial infarctions with PCI compared to surgery, because now we use the Zion stent. The stent thrombosis rate was so low, it was lower than the graft failure rate. So there were fewer myocardial infarctions, very low mortality, about 1% at 30 days, very low stroke rates, tending to be less than with surgery. Patients went home faster, and they had much better early quality of life. And when you get out to 3 years and now out to 4 years, we just reported the 4-year data, the overall outcomes of the main endpoint, death, large MI, or stroke, are similar. So I think that it's important to note that in Excel, we enrolled patients with low and intermediate Syntax scores. The most complex patients, the ones with high Syntax scores, left main disease and triple vessel, complex triple, those patients will still do better with surgery, even with contemporary drug-eluting stents. But I would say for many patients, I don't know if it's half or some number around there at least, I think PCI is a very favorable, maybe even a preferable alternative.
I read the very interesting report, the recently published in the Lancet in the meta-analysis for the mortality from the 11 randomized trial. In the CABG is better. However, in the subgroup analysis, left main is no difference.
That's exactly right. For the left main disease, the mortality was identical with or without diabetes. But in multivessel disease, it still favored surgery. And what that shows is it's not really the left main. again, with our current techniques, an experienced interventionalist can handle the left main very easily.
Right.
The problem is the rest of the disease. And it's not only all the other disease that you're treating, but it's the other disease there that you're not treating as an interventionalist. And the surgeons do have an advantage because when they bypass an artery, it's bypassing not only the high-grade lesion, but it's also bypassing what may be 30% plaques or 50% plaques that might cause trouble in the future. And I think there is some truth to that. So very diffuse and extensive disease, I think those patients will do better with surgery. But for the patients with either simple or moderate complex disease, with or without left main, then I think they do excellent with PCI, and it's a safer, easier procedure.
In the I'd like to move to the next issue about the imaging and physiology, and including the QFR.
Yes.
Is there any comment about the opinion about the two?
Well, we're going through an imaging revolution and a physiology revolution. And the most important things are that if we're going to do an intervention, we have to intervene on the correct lesions. We don't want to miss lesions that should be intervened on, but we also don't want to treat lesions that don't need to be treated. Because there's always risks of every procedure and expense. So in that regard, physiologic assessment, okay, first with FFR, but then with IFR, and now maybe QFR, and then maybe also with FFRCT, which is an emerging, very excited modality that we're doing a lot of studies with. This is really defined, being able to identify which lesions are physiologically significant, which are causing ischemia and therefore angina, and today are reducing quality of life. And most studies have shown that treating those lesions are the appropriate ones to focus on. Now, there's a whole nother story, and that's about vulnerable plaque, right? That's about
prospective study.
Right. That's about the 30% lesions, that are angiographically very mild, but there's a fair amount of bulky plaque. Not so severe that they're causing physiology today, but they may thrombose in the future and cause a myocardial infarction or an acute coronary syndrome or rapidly progress. And we had shown in the prospect study that you can identify those lesions by the use of radiofrequency intravascular ultrasound. And just 2 weeks ago at TCT, Ron Waxman presented the results of the lipid-rich trial that shows that with near-infrared spectroscopy, looking for lipid-rich plaques with a lot of cholesterol content, you can also identify those mild plaques which are likely to progress within a 2-year time frame and cause a acute coronary syndrome or progressive angina. So I think that today we're very good at physiology, and we should be incorporating physiology into our treatment decisions, either before we get to the cath lab, like with FFRCT, or in the cath lab, with FFR and IFR being established, and in the future, maybe QFR and other angiographic-based techniques. But that is better than the eye, and then that's also better than ultrasound or OCT, because just because you see a lot of plaque doesn't mean it's physiologically significant. In the future, though, I think we'll be using imaging such as near-infrared spectroscopy and ultrasound and optical coherence tomography to also potentially identify vulnerable plaques for either intensification of medical therapy or perhaps for even focal treatment. And then finally, of course, we should be using both intravascular ultrasound and or optical coherence tomography more to guide our stent procedures. So once we've decided to stent on the basis of physiology or a very severe stenosis by the angiogram, then we want to get the best stent result possible. And study after study after study has shown that even in the contemporary drug-eluting stent era, using intravascular imaging to optimize stent dimensions and make sure you're treating all the disease and don't leave major residual dissections will lead to a lower rate of MACE, both restenosis and stent thrombosis. And people have to develop that expertise and develop the pattern of using intravascular imaging routinely. We just had a TCT again 2 weeks ago, the report from Xiaolin Chen's group in China from the ULTIMATE trial, in which nearly 1,500 patients were randomized again to angiography-guided versus intravascular ultrasound-guided stenting.
ULTIMATE study.
You saw the ULTIMATE study, and about a 50% lower rate of adverse events at the end of 1 year. That's like the 10th randomized trial that have all showed the same thing. But still, except for in Japan, where intravascular imaging is like 90% or 95%. The rest of the world, at least the United States and Europe, does not use routinely intravascular imaging during PCI. You can tell me, what is the rate in South Korea of imaging guidance in PCI procedures?
Actually, we have the more interested in, actually the volume of the PCI is not much in each center.
Yeah.
So we can have more time to concentrate.
Good, you can.
So we try to use some imaging or physiology or
Good.
specific.
In almost most patients?
Yeah, not actually most cases, but if it is an indication, particularly in the complex lesion,
Yes.
CTO
Yeah.
or bifurcation, and the long lesion, left main lesion. I'd like to ask the same question in the aspect. The using of the imaging is very important in the complex lesion.
Yeah.
Why it does not use in the Europe or United States? Mainly in the money. So I know that, but
that's part of it. The reimbursement is part of it, but I think there are two other issues. One, people see it as complex to use. Okay, it gives you so much information, and I think that we haven't done as good a job training people as that we should have. And a lot of people don't know how to interpret the images. So you can get information overload. You see what do I measure? Where do I go? So we need to more practically educate people how to use intravascular imaging. In the early days, of course, the ultrasound images were very poor, and it really took an expert to analyze them. But OCT has gotten very excited in that regard because now the images are very, very clear. But I remember the first time I saw OCT, I said, "Oh my God, look at all this information! Now
Very
I can
clear.
really measure everything and frame by frame." So that's number one, the information overload. Number two, I think it takes time to use imaging, and at Columbia University, we're very fortunate. We have an imaging team.
Right.
So
I heard
if I
that.
yell, I want to do an ultrasound, all of a sudden 3 people come running and bring the machine over, and we just plug it into the cath lab, and then I just do the case, and then they measure. They automatically measure, and they know exactly where to measure. But a lot of people don't have that. And a lot of people, the doctor has to do the pullback, and then go there and make the measurements, him or herself, and that takes time. So unless they're very, very convinced that it is worth it for their patients, then they don't do it. And many people say, I haven't had a stent thrombosis in 5 years, so why do I need ultrasound or imaging, or I never see restenosis. We know that's not true, that no one's experience is big enough, and we know that people are having those events, but they just can't put them all together in their minds. So I think it's training, it's a lack of feeling an urgent need to do that procedure, even though I think it can be a 50% reduction in events. And yes, then there is the reimbursement issue. Again, for all those reasons, I think in the United States, it's probably 15% of use, of all PCI procedures, about 15%. In Europe, it's probably half that. So in my cases, 75%, because I believe very strongly. It's only the simple big lesions, maybe those I won't, but for almost anything else. So I'm very jealous, particularly of Japan, where they get good reimbursement and all the doctors know how to use. So they're 90 to 95% of all their PCI procedures are getting imaging.
I think that the use of the imaging should be classified by the experience of the operator.
Yeah.
As you say, in your institute, a lot of the master and a huge number of experts. But when we look at some doctors who working in the small town, small experience, there is no mentor or but some of the discussants say that I don't need the imaging modality, but it is the situation is not similar to the doctor who worked in the small town.
Right.
So these doctors need the imaging. What is try to realize that what is the fact. So particularly small number of the experienced doctor, they need it.
But hopefully those doctors will come to the Korean Society of Cardiology. So they will hear about this and they will see the data. Because as you say, there are a lot of doctors that do only 50 PCIs a year, at least in the United States. I don't know if that's true in Korea. And those, so one a week, and they will have higher complication rates or not do complicated cases because they don't have a lot of experience. And intravascular imaging to me takes the guesswork out of doing angioplasty. Without imaging, I'm trying to, should I put a 2.5 stent or a 3.0 stent? And is it 18 millimeters or 24 millimeters?
Right.
Imaging takes all the guesswork out of that.
There is the
It
answer.
lowers my stress level.
Right.
Yeah.
And if you do the imaging up front, then you plan your procedure, and then the imaging at the end is almost unimportant.
Yeah.
It is, you'll still occasionally see things, but if you measure the vessel size right, if you learn what the plaque characteristics are, so you learn how hard you have to prepare the lesion, if you see the extent of the disease, so you know how long a stent is and what the different diameters need to be in different locations, then you go bang, 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 and you put in the stents according to plan, and then, yes, you image at the end to see that it all looks good, which it does 90% of the time, and you'll be very happy.
There is another great advance in the software, in the particular in the OCT.
Yeah, especially the OCT.
Automatically, everything
Oh,
is
with the co-registration too,
Right.
where you pull back and then it shows you exactly where the lesion is. It's very good.
Finally, the final question is, what is the next research field for the intervention field? What do we have to focus?
You know, there's not just one thing.
Okay.
There are so many areas of interventional cardiology. And are you talking coronary intervention, or because when I think of interventional cardiology right now, it's coronary, it's structural heart disease, and then it's peripheral vascular disease. Obviously, right now, a lot of the excitement in the growth areas is in structural heart disease. Both TAVR and mitral valve interventions and tricuspid valve interventions and left atrial appendage and PFO closure and heart failure therapies, very exciting areas. So if I was going to say where the biggest growth and the biggest breakthroughs are going to be, I think they're going to be in structural heart. But I do think in coronaries, we're going to keep making a lot of advances, whether it's hybrid revascularization, whether it's new approaches to CTOs, large randomized trials about calcium ablation, large studies about OCT to guide therapies, newer drug, Lumion 4, newer drugs, adjunct medical therapies, very, very important in concert with what we're doing. There's going to be new personalized ways. We talked about physiology. I really do think that the FFRCT and pre-cath lab assessment to define the coronary anatomy, physiologic significance, plaque characteristics. So before you even get to the cath lab, you can know what you're going to do. Is going to be very, very helpful. So I think there'll be, and then again, I'm also still optimistic about bioresorbable scaffolds. I don't think that story has ended. I think that once we get to scaffolds, 100 microns or less, we now know the better technique to implant them. I think that we can have better results within the first few years before they absorb, and then really superior results in the long term once the patient, his arteries are restored to their natural state. So it's a very exciting time for interventional cardiology on all of those fronts, and I'm excited to be a part of it, and hopefully we'll be invited back to talk about some of those advances in the future.
Today your lecture is very interesting and very helpful for me. And you believe we need some more technical improvement for stent deployment technique?
Yeah, I think that the stents have gotten very good, but the technique is very important. I think that more than, yes, maybe if we make the stents a little bit thinner, as long as they're strong enough, they can get a little bit better because they'll endothelialize faster, and both thrombosis and restenosis may be reduced a little bit. But I think we can have even bigger impact by the technique, but for both metallic stents and definitely for bioresorbable scaffolds. And that is, again, first knowing which lesions to treat and which not to treat. Then second, knowing what's the largest you can expand the stent, image guidance. And to expand a stent fully, you need to know the size of the media, okay, not just the lumen, the media. You need to prepare the lesion adequately, whether that's with atheroablation or other techniques in the case of fibrotic or calcific disease. And you then know you need to treat disease at the edges. So you can't leave diseased plaque at the edges with 50 or 55% more plaque burden, and you can't leave significant dissections, which you often can't see. So we need intravascular imaging guidance. And then, of course, when you talk about CTOs, yes, technique has totally revolutionized our ability to successfully treat CTOs. Complex bifurcations and trifurcations. What we call CHIP, complex and high-risk indicated patients with reduced ejection fractions, where you need to use advanced hemodynamic support devices, and other advanced techniques. So with these new techniques, we're able to successfully treat most patients with complex coronary disease who either are or are not surgical candidates. And so, again, a very exciting time to be part of the PCI field.
Okay.
I really appreciate you and your time. This is
My pleasure.
I purely monopolize your opinion. It's a very good chance to me.
Thank you so
Yeah.
much.
Please close.
I'd like sincere thanks to Dr. Greg Stone and Dr. Young Gi-hong for great discussion and great interview. So I'd like to close this session. Thank you very much.
Thank you.
Thank you.
Okay.
Really excellent.
Great. That was
Excellent
fun.
discussion. And
Thank